Hi everyone, welcome and thank you for joining us for this PRS Grand Rounds event. My name is Jordan Fry, Resident Ambassador from NYU. I'm here joined virtually by my co-ambassadors Chad Purnell from Northwestern and Shuja Shafkat from Lehigh Valley. After the overwhelming success of our first Grand Rounds event in the series featuring Dr. Rod Rohrich, we couldn't be more excited at PRS to welcome Dr. Alexis Hazen from NYU to give the second installment of our Grand Round series entitled Female to Male Transgender Surgery, an overview of top and bottom surgery. Dr. Hazen is an associate professor of plastic surgery at NYU and director of the Aesthetic Surgery Center. She completed her plastic surgery residency and subsequent microsurgery fellowship at NYU, subsequently joining the staff after graduating. And she's developed an interest in transgender surgery and really become one of the foremost experts in the field, lecturing nationally. She's especially developed an interest in assessing and become an advocate for improving patient-reported outcomes in the transgender community. As a quick note before we start, I'd like to remind you all to submit your questions here on Facebook or even on Twitter using hashtag PRSGrandRounds, as there will be a live Q&A session with Dr. Hazen at the conclusion of her talk, where she'll answer as many questions as possible. Also, remember, we have a free compendium of related articles cultivated to accompany this presentation available at prsjournal.com or using the link below. These are all articles available anytime for free related to this Grand Rounds on transgender surgery, including Dr. Hazen's recent review of female to male transgender genital reconstruction featured in this month's edition of PRS. So without any further ado, it's my honor to welcome one of my mentors, Dr. Hazen, giving her Grand Rounds talk on female to male transgender surgery, an overview of top and bottom surgery. Dr. Hazen.
Thank you. I'm really honored to be giving this talk. It means a lot to me, and I am very grateful to Dr. Rod Rohrich and also all of the staff at PRS and the resident ambassadors. I think it's a really important topic, and it's great that we can be doing this and reaching people really all over the country and all over the world. So we're talking tonight about transgender plastic surgery, and I think recently there's been a lot in the media about it, about transgender issues in general, and I'm very pleased about that because I think it's an issue that we need much more information, we need much more education, and we need to create an environment that's safe and healthy and loving for our patients and friends who are transgender. I'm going to be specifically talking about top and bottom surgery in female to male patients. So just starting with a couple of sort of clarifications. So what is gender identity? It's one's concept of self as female or male, or both, or neither, and how individuals perceive themselves and what they call themselves. And a gender identity can be very different than what you were assigned at birth or the same. Another sort of clarification is sexual orientation, which is an enduring pattern of romantic or sexual attraction to the opposite sex or gender, or the same sex or gender, or both. And they're different. So gender dysphoria is a diagnosis that is a DSM-5 diagnosis, and I hope in the question and answer we can talk a little bit about this, but it's basically distress a person experiences as a result of the sex or gender they were assigned at birth as being contrary to their gender identity. So it means that those two things are not in sync, and that gives them dysphoria. It used to be called gender identity disorder, and there's a lot of terminology that we've sort of moved away from. This kind of surgery now we tend to call gender affirming surgery, and it used to be called sex change operation. In terms of numbers, we don't really know because it's probably very underreported, but likely the worldwide population is greater than 15 million and as many as 2% of the US population, which translates to a very large number. So historically, mostly surgery and kind of information about this was male to female. The first surgeries were done in Europe, and the first American patient was Christine Jorgensen, who got a lot of press because they were an ex-GI. and that was in 1952. In 1966, Johns Hopkins opened the first gender identity program, and Harry Benjamin's book came out discussing this issue. 40 subsequent centers opened, and the Harry Benjamin International Gender Dysphoria Association started in 1979, recommending standard of care for treatment of this population. One of the things that I think is really important and a big problem is barriers to care for all patients. And there is a lack of entry into care for insurance and safety reasons. There are also financial barriers. There are also barriers within the medical establishment in that many centers are not trans friendly. And so this is something that we really need to work on collectively as physicians and as human beings in terms of creating formal education programs of residents and health professionals, and to update our electronic record keeping, which is very outdated for this issue. And there's a very binary system of female to male oriented structure of most electronic health records that doesn't allow for anything different. And so it creates a lot of confusion, and for our patients, it creates a lot of stress. So WPATH came about, which is the World Professional Association for Transgender Health, to create guidelines and guidance for health professionals who wish to assist in transgender patients and gender nonconforming people. And that is sort of what we all as practitioners should adhere to, and it's a guideline for taking care of our patients, and it's a very important thing to adhere to and to understand. So one of the things about dealing with any patients, but especially I think transgender patients, is when you are embarking on taking care of them, you need to make sure that they have support in this journey, and that they have, if not family, they have friends who are family, they have a safe environment to go to post-surgery if they're going to choose to have surgery. And we as physicians need to help support our patients and make sure, as we're assessing them, that that is something that is part of their setup for especially for post-op. It's very, very important. So there are many aspects of transitional surgery or gender affirming treatment, and one of the components is hormonal therapy. But it is not necessarily, there's not a cookbook for how people embark on their transition. And some patients start with hormonal therapy, and then they go on to have surgery. They may go on to have top surgery, which we're going to discuss, and or bottom surgery. Some patients choose never to have hormonal therapy, either for medical reasons or because they just simply don't want to embark on that. And some patients only do hormonal therapy. The goal of hormonal therapy in female-to-male transgender is to induce virilization, and there are a lot of changes specifically about the secondary sexual characteristics that happen, and they usually happen over a period of about a year, but can increase and change for up to about 5 years. So now we're going to talk a little bit about bottom surgery, which is essentially genital reconstruction. So in creating a neophallus, there has been some discussion about what is the ideal neophallus, and we're going to talk a little bit about that later. Ideally, the surgery could happen in one stage. It would be aesthetically pleasing. It would have sensation. It would allow for sexual function. It would allow for standing urination, and the donor site wouldn't be something that was too dysforming, and low overall complications, and then subsequently could allow for scrotoplasty in the future. So there's sort of many different options for creating a neophallus. Metoidoplasty is one of them. in the influence of hormonal therapy, the clitoris enlarges tremendously, and basically that can be used to create a neophallus. The surrounding tissue, using local flaps or using skin grafts, can be fashioned to create a urethroplasty to allow for the elongation of the urethra, to allow for standing urination, among other things. Advantages of this surgery are that it's generally able to be created in one stage. There is really limited donor site scarring. It's a relatively short operation and less expensive, and a short hospitalization and quick recovery. The disadvantages are that the neophallus is quite small and short, and that depending on the goals in terms of sexual penetration and standing urination, it may impair those abilities. So there are many other options for creating a neophallus, and the other options are called phalloplasty. So there are pedicled flaps. There are many, many different options for that, including an anterolateral thigh flap, abdominal flaps, and groin flaps, which can be fashioned to create a neophallus, together with tubularization for the urethra. There are also options for free flaps, and the workhorse of that is typically the radial forearm, although the anterolateral thigh flap has also been used in recently much more. The advantages of that are that you can create something much larger. It's very reliable in terms of its blood supply. You can also bring nerves with it, which theoretically could increase the sensation of the flap. The problems with it are that it usually cannot be accomplished in one setting, and so to create the urethra, it usually has to be a staged operation where you're crafting a tube within a tube. And for the urethra, there are many options which can be used: skin, mucosa, even vaginal mucosa, but it means having a flap, a two-staged operation at minimum. The advantages of this operation are it's very, very reliable with low rates of flap loss. You can create a very large neophallus, and in our studies and other studies, there's a very high reported aesthetic satisfaction. And as I mentioned, since you can take a nerve with you and connect it to the ilioinguinal nerve or other nerves in the area, there is ability for erogenous sensation. And in some cases, it can be completed in one stage. The disadvantages are that it's a long operation, and the longer the urethra, or the urethral reconstruction, really that correlates to higher rates of urologic complications. And the rates of urologic complications are quite high. And it also is a very visible donor site and it's on the forearm, so it's very hard to hide. The other issue is that sometimes people have tattoos there, and they're hard to remove. Other free flaps that are available for options are the fibula flap, the lateral arm flap, which is not typically used. The fibula flap was very commonly used in the past, but it has a higher rate of failure. The advantage was you could take some bone with it, which would allow for sexual penetration without the placement of a prosthesis. Other free flaps are the latissimus dorsi and thoracodorsal perforator and the anterolateral thigh flap, which I mentioned before. Adjunctive procedures for phalloplasty include total hysterectomy and salpingo-oophorectomy, vaginectomy, scrotoplasty, which can be accomplished with many different materials, including silicone or fat grafting, and then insertion of prosthesis, because most of these flaps, other than the fibula, would not allow for erectile rigidity, which may make sexual penetration not possible. So often at a later time, once everything is healed, an insertion of a prosthesis is advised. So most of these procedures, as you can see, since they're in multi-organs, are best done with a team approach. And the addition of a urologic or gynecologic colleague is really key to the success of these operations. So in the future, will it be possible to potentially use penoid transplantation as an option for these patients? So far, it's only been described for traumatic or oncologic deformities, but it could be theoretically extended to FTM patients, which would potentially provide the most perfect reconstruction. Obviously, the burden is lifelong immunosuppression, but however, if we could figure that out, then this would probably be the ideal solution. Now we're going to move on to top surgery, which is essentially chest wall reconstruction. In planning for top surgery, as with bottom surgery, you need to adhere to the WPATH guidelines, communicate with patients, staff and physician training is key, and you need to evaluate the patient in terms of psychological, medical support, and their medications. All patients are required to have a psychological evaluation, and for bottom surgery patients, usually 2 psychological evaluations. The other aspect that's really important is screening every single patient for breast cancer. And for patients who have a high risk of breast cancer, you should consider sending the patient to an oncologic breast surgeon for additional evaluation and possible testing. And patients need to understand that even though you are removing essentially 99% of the breast tissue, that they once had breast tissue there, and they always have a potential risk of breast cancer and need to be evaluated for forever with a physical examination. So what is top surgery? It's basically the removal of the breast tissue and reconstruction of the chest to appear more masculine. We take account differences in nipple shape, size, and placement on the chest wall. Usually, in most patients, it requires skin reduction, and patients who have been binding for long term usually have much more ptosis and hence much more skin to excise. We talked about planning and considerations. Another serious consideration is smoking, and in my patient population, I require that they stop smoking prior to the surgery because the flaps can be very long and they have to be tight for things to look good. So I consider it to be a contraindication to an effective surgery. And so I make my patients stop smoking. So algorithms have been developed, especially by Monstray, and which take into account the size of the breast, the skin quality, the skin ptosis, the size of the areola, and the size of the nipple. And with that algorithm, you can come up with options for breast surgery. So ideally, when you are transforming a female to an ideal male chest, you want to create a contour that's smooth, an incision that lies in the fold right underneath the inferior border of the pectoralis major with a gentle slope laterally. The ideal nipple position is at about the 4th intercostal at the lateral border of the pectoralis major, and the areola is oval, not round, and it's quite small, 3 centimeters at the maximum, and the incision shouldn't meet in the center and shouldn't go past the mid-axillary line. So there are many different techniques which have been recommended for this type of surgery. For patients who are very, very small and have minimal ptosis, it's possible to do the concentric circular technique, or which has also been called the Benelli technique, where you essentially remove a circle of skin and the breast tissue from that, so you end up with a scar that's just around the areola. The disadvantages of it are that it's hard to move the nipple and areola to the ideal position if it starts out quite medial. And there, with the purse stringing around the nipple areola complex, there tends to be a high revision rate in fixing that and smoothing it out. Pedicle technique is the only technique that can preserve nipple areolar sensitivity. And how that's done is by leaving the nipple and the areola connected to the chest wall through the breast tissue. And then it's brought through a keyhole on the proper skin position. The problem with it is that the only way you can do it is by leaving a fair amount of breast tissue behind, so it tends to be rather full looking. But for patients who really want to have nipple sensation, this is the best technique to use. Then for many patients who have large breast volumes and a lot of ptosis, the only option for them is what we call a double incision. And in the past, the only option was to use a free nipple graft. The problem with a free nipple graft is that it often loses pigmentation, you definitely lose sensory, and the graft on the areola usually takes quite well, but often on the nipple it doesn't take very well. So problems with top surgery, on the left you see what the effects of binding are, and it just creates a lot of extra skin, and that can end up in longer scars. The shape of the areola is really important, and a very round shape isn't as aesthetically pleasing as a more oval shape, and incisions that either meet in the middle, are too curved, or too straight don't look right either. So I developed a technique that took into account all those considerations, keeping the incision off of the midline, keeping it not beyond the mid-axillary line, resecting and marking the resection, and then rather than doing a free nipple graft, creating a very small nipple using just a skin flap, deepithelializing it in the correct position, and then grafting the areola like a donut on top of it. And that has proven to be a very reliable technique and allowing placement of the nipple and areola complex where you want it, and allowing for a nipple that has the right size and projection. These are just some before and afters. So where are we now? We need to really understand what patients want and what the whole idea of an ideal neophallus, how do we know what that means? We need to ask patients. We need to talk to patients and find out what they want, what their desires are. We need to find out how happy they are with their surgeries, and we need to do this on a very large scale. And there is a real paucity of information in this field right now, and I would encourage anybody who's going into it to really look into this. So one of the essential research questions is, does the surgery alleviate distress or act as a prophylaxis against distress? Does the surgery improve quality of life, social, psychological, or occupational functioning? And does it contribute to alleviating personal distress associated with gender dysphoria and other mental health conditions? So these are all things that our group is looking at NYU, and we're very interested in. These are a bunch of references, and I'm supposed to end on the 5 things you need to know if you're going to go into this. So I think the first, and I don't know, most important thing is, if you're going to go into this type of surgery, you need to go into it not to make money. You need to go into it because you love it and because you care about the patients and you want to do better and you want to help people change and improve their lives and become happier and more comfortable with themselves. Second, you need to educate yourself about the population and the terminology and the WPATH guidelines. Third, you really need to create a team. You can't do this alone. You need urologists, gynecologists, endocrinologists, and you need psychological support for the patients. Fourth, you need to start studying what works and what doesn't work and analyze your patients and find out what makes them happy and the problems that are really unsustainable for them. And then I think the last thing is we need to really ask questions, specific questions about, for example, about the ideal neophallus. What is ideal? Who says what's ideal? We need to ask very specific and directed questions to all our patients to find out information rather than just making assumptions on what's been done in the past. So with that, I thank you for listening, and I'm very happy to take any questions.
All right, that was great, Dr. Hazen. Very educational and very exciting. We have a lot of questions coming in, so I think we'll get right to that.
Okay.
First one from Sydney Boya. Do patients ever stop hormone therapy after a certain period of time?
That's a great question. Yeah, they do, and sometimes patients don't start hormone therapy, so it's very individual. And so there are many patients who, for either health reasons or just personal reasons, choose not to start hormone therapy. And then by the same token, patients may stop. For patients who are taking testosterone, it usually requires an injection. And I've definitely had some patients who had a very hard time giving themselves an injection. And so for a period of time actually went off testosterone just so they could relieve themselves of that burden of giving themselves an injection. So yes, it's very individual for each patient.
All right, so we have another one. This is actually from PRS Global Open. So in reference to your PRS Global Open paper, reviewing metoidioplasty and radioforum flat phalloplasty, what do you think is the patient takeaway from that paper?
Well, it was interesting because there are many more complications with the radioforum, but patients who choose either one are happy with what they've chosen. And so even the patients, there's about a 40% complication rate with radioforum for urologic complications, but those patients are happy, and so are the metoidioplasty patients. So I think maybe the take home is getting really good pre-op information about the limitations and the benefits of each surgery. I think that's the most important thing.
All right. We have one here from Christina Yee, who says, thank you, Dr. Hazen. Do you work with adolescent patients? And if so, for female to male adolescents, would you encourage them to pursue hormonal therapy earlier to affect later surgical changes, such as having less breast tissue to remove later on?
So, Christina, thanks for your question. It's a great question. I think if the patient is very certain that that's what they want and it's not a phase. There's many adolescents go through a phase where they question everything, including their gender identity. But I think for patients who really have always identified a certain way, that it's very reasonable for them to go on hormonal therapy at a young age to prevent the secondary sexual characteristics from occurring. And I do have a number of patients who have done that, and they must have their family support. And because unless they're emancipated, which is not typical. So with family support, with thorough evaluation, I think it's a very reasonable option.
All right. We have another one here from Ara Salabian. It says, great talk, thank you. What do you find to be the most common and the most difficult secondary procedures or revisions in female-to-male top surgery?
Probably if the nipple is in the wrong place, and if it's too high, or if the incisions are just the basic incisions are just in the wrong place. Sometimes that's very hard to correct. If the incisions are too low, sometimes you can't raise them, and they just never look right. Things like excess tissue, or a nipple that's too large, or even a divot. if they're hollowed out, those are easy to fix. But things where the incision is just in the wrong place, then that can be sometimes pretty tricky.
All right. We have one off of Twitter here. We have Megan Lane ask, do you hold testosterone for a period of time pre-op before top or bottom surgery?
This is a great question. There were a couple of studies a while ago, probably 10 years ago, that thought that testosterone could interfere with wound healing. So when I first started doing the surgery about 8 years ago, I did hold testosterone, and I would not have my patients take it for 3 weeks before and 3 weeks after. Subsequently, though, I had some patients who ended up taking their testosterone for whatever reason. I don't see any difference in the patients who take testosterone or don't. And so I allow them to take it because I think for their overall sense of well-being, it is more important that they maintain sort of a steady state of their testosterone. But some surgeons do require that their patients go off their testosterone. I just haven't seen any good evidence that would lead me to come to that conclusion.
Okay. We have another one here. This is from Chad Purnell. It says, should you maintain the support of the IMF, inframemory fold, in top surgery, or do you undermine it?
That's a good question. So it totally depends where the IMF is in relation to the insertion of the pec muscle. So if the IMF is, you basically want the incision to lie at the insertion of the pec muscle at the, and then laterally a little bit higher. So if that corresponds to the IMF, then yeah. If it doesn't, then you want to undermine it and lift it up and cut off some of that skin. And the main thing is to make it really tight, which is why patients, have to be healthy and they can't be smokers.
Okay. Another one here, we have Selenide Gonzalez. She asks, what recommendations do you have for breast cancer screening in your top surgery patients?
Good. I'm really glad you asked this question because I think it's kind of ignored. So I asked them about family history and personal history. And if their family history has a significant risk, then I send them for both genetic counseling and I send them to an oncologic breast surgeon. And then sometimes they end up getting genetic testing done. So I screen them not just for breast cancer, but for all family cancers. And I've had a number of patients who were BRCA positive. I've had patients who actually had breast cancer and but wanted male chest wall reconstruction, and they ended up having chemotherapy after the surgery. So I think just family history, personal history, and you have to include other cancers other than breast.
From Nikki Phillips, we have another one. What type of training do you recommend for office or other support staff in order to ensure a safe space for transgender patients?
That is a really good question. So in some institutions, there is formal training. And if that exists, obviously that's ideal. So at NYU now we have a consultant and we have a formal training program, and all offices that are involved with transgender patients do get that training. If that doesn't exist, then just somebody who is an expert and can talk about sort of the right terminology and making people a little more sensitive and less quick to judge, I think is helpful. So ideally it would be a program that exists, but sometimes that isn't the case, especially in a small community hospital. So then just bringing somebody in who is an expert. And everybody needs to be trained, especially the first people who meet patients, because that's their first impression of the office. And so the people who are doing the intake really need to understand and be sensitive and try to use the right language.
Okay, those are really great tips, I think, for anyone kind of getting started, and that's important things that you have to think about. Let's see, we have some more coming in here. We have Grace P. She's asking, what has your experience been with getting insurance coverage for these procedures?
Varies tremendously. I think that when Andrew Cuomo in New York promoted this and made the recommendation that Medicare and Medicaid pay for it, that helped a lot because commercial insurances followed. But we often have a case where insurance will cover some things, but not others. For example, often there are many insurances which will cover the mastectomy and the closure, but they won't cover the nipple reconstruction because they consider that cosmetic, which is absurd. I mean, either it's reconstruction or it's not. And we appeal those cases and we make a big fuss and we call the attorney general, but it varies state to state and it varies insurance company to insurance company. And I think it's, we were able to make great strides in the breast cancer coverage of insurance by protesting, by going to Washington and talking to our representatives. And I think with this surgery, we need to do the same thing because it's not cosmetic surgery. It's reconstruction and it's life altering and it should be covered.
All right. We've still got a lot of questions coming in here, so everyone, we encourage you to keep asking. We have Pat McGuire who asks, any tips for female to male top surgery in high BMI patients?
Yeah, so if you're high BMI, your results are going to be not optimal. And the problem is if you hollow things out in the chest, then it doesn't look right with the body. And so in a way, you have to sort of leave a little more tissue, and it's not breast tissue, but it's just fat. And so some patients aren't very happy with that. And also there's sort of an issue with seroma and healing in higher BMI patients. So I try to encourage people to lose weight. And I had one patient who left and lost like 100 pounds and came back and they have a great result. I still would do the operation in high BMI patients, but they definitely have not as ideal a cosmetic result.
Let's see. Next, we have Gram Positive. It says, do you have any tips for medical students or residents interested in gender-affirming surgery? How important is the residency program that you choose in terms of exposure and training in gender surgery, if that's something you'd like to do in the future?
I think it is important. I mean, I didn't learn it till after I was out of residency, but if there were a residency program that existed that had attendings that were doing the surgery, I would choose that one over other ones. But can you learn it on your own outside? Yeah, absolutely. That's most people who are doing the surgery now didn't learn it in residency. But I think ideally, if this is something you're interested in, then you should go to a place that has people who are doing the surgery, like NYU.
Next, from Nicholas Berlin, says, great presentation. Can you discuss your general approach to urologic complications like fistula, stenosis, following phalloplasty? Do you get urology involved early on? Do you take care of these on your own? What's your advice there?
So my advice is absolutely urology. And these procedures should be done with a urologic surgeon unless you're in a location where no urology exists, because that's really their expertise and their specialty. And our specialty is everything else. But that is really where they excel and they know more and they know how to treat these and they see them all the time. So I would, partner with a urologic surgeon and then, together you can manage this, but it's really their expertise and that they know more about it than anybody.
All right. I think we have a good question here. This one comes from Huda Sheikh. She says, should gender dysphoria be considered a pathological diagnosis?
That's a great question. And I actually, if I have a longer talk, I always talk about that. So no, in my opinion, no, it's not pathology. It's how people feel. And if you look back on the DSM and pathological diagnoses, being homosexual was a pathological diagnosis, which now we think is absurd. So I think we will think that it's absurd that we categorize people like this. The reason why we as medical practitioners do it is for insurance coverage reasons. And so to get the surgeries, you have to have this diagnosis. And so that's why we do it. I think I have a lot of patients who are very uncomfortable with it, and I'm personally uncomfortable with it because many of my patients, or most of them, don't consider they have any kind of disorder. They just, this is who they are, and that's that. So yeah, I think it's a necessary evil right now, but I hope that things will change and we will become more evolved.
All right. Well, I think with that, we're going to draw to a conclusion this edition of PRS Grand Rounds. I want to take this opportunity to especially thank Dr. Hazen for graciously giving us her time and all this wonderful information and great talk. I think we all really learned a lot, and this was excellent. So thank you.
Thanks. This was fun.
So as a few reminders to everyone, stay tuned. Check out the PRS Facebook and Twitter pages for more information about upcoming initiatives, especially upcoming PRS Grand Round events. We have some great talks lined up in the future. We have some tentative speakers already. Robert Murphy discussing leadership in plastic surgery, Heather Furness discussing women in plastic surgery, and John Kim discussing innovations in breast surgery. So definitely stay tuned for that. And we'd like to invite everyone. We have our edition of the award-winning PRS Journal Club coming up this Sunday and Monday. We have a great paper we're discussing by Dr. Hidalgo and Andrew Weinstein on anatomic versus round implants in breast augmentation. And this is on Twitter, so we'll interact directly with the authors. This will generate a great discussion. So we really encourage you all to join on and just go to prsjournal.com and look for the Journal Club logo. So again, I just want to thank everyone at PRS that makes this possible and for committing all of your time for all of these great initiatives. My co-ambassadors, Chad Purnell, Shuja Shafkat, managing editor Aaron Weinstein, and editor-in-chief, of course, Dr. Rorick, and everyone at PRS. Thank you so much. And again, Dr. Hazen, thank you for joining us.
Thank you. This was fun. We'll do it again.
We'll see you all soon.
Okay, bye.